Fluctuations in vitals also.
6:05.
Last time you sang.
Can we start? Because people will start joining, I hope.
Yes, please go ahead. Please go ahead.
Yes, ma'am. We are already live, ma'am. Dr. Gauri?
Yes, sir. We are ready to begin, sir.
With your due permission, President, ma'am, can we please go ahead, ma'am?
Please, sir.
Dr. Gauri, over to you, please. Please go ahead.
Good evening, everybody, and a very warm welcome to all of you on behalf of the Rsacp Mumbai branch for our webinar series in the 2022. We welcome you to our academic webinar on problem-based learning. Before we begin our webinar, I'd like to welcome everyone to this diet on this lovely rainy evening. I'm hoping that you are enjoying the same weather that I am. Before we begin what promises to truly be an academic feast, I'd like to invite Dr. our respected patron to say a few words. Over to you, sir.
Vishal, can you please mute others?
Mute themselves, please, so that we can enjoy what Dr.
We can hear Dr. Tej call. Can you mute others, Vishal?
Hello.
Mentally,
Vishal, can you please mute others?
Yes, ma'am.
Subjects గుర్తుంటాయి లైక్ గైనక్స్ పీడియాట్రిక్స్ ఇవి గుర్తుంటాయి బేసిక్ అనాటమీ
Yeah. Okay. No, it's not.
చదివేదాన్ని అంటే కొంచెం క్లినికల్ టీమ్స్ లా ఉంటే బాగుంటది.
Shall mute everybody. Mute everybody once at
Sir, I'm not getting the
point
button available, sir.
There is a lot of talk going behind. Please stop. Mute all of them.
Surya Srivastav. Surya Srivastav.
Sir,
నేను ఫస్ట్ ఏవి చదవాలో కాకుండా ఏవేవి చదవద్దు అది రాసుకున్నా అన్నమాట.
Surya Srivastav. Mute yourself.
Sir, Naveen sir, can you please make me the co-host, sir? Naveen sir, can you please make me the co-host? All of Dr. Gauri, please go ahead. Unmute yourself, Dr. Gauri. Please go ahead.
Yes, sir. Yes, sir. Before we begin what promises to truly be an academic feast, I'd like to invite our patron, Dr. Tej Kaul, to share his wisdom with us.
Welcome everybody to this academic feast as suggested by Dr. Gauri. It is an experience to have dynamic people managing the Rsacp academic series this session under the guidance of Dr. Indrani, Dr. Vishal, Dr. Naveen, and all the members of the governing council. I wish best for this academic program. All the best. Please go ahead.
We are joined by our very illustrious President-elect, Dr. Naveen Malhotra. I'd ask him to say a few words for our assembly, please.
Thank you, Dr. Gauri. Heartiest congratulations to Team Rsacp and Team Rsacp Mumbai branch. I place it on record that today we are completing 2 years of Rsacp academic webinar. We started on 1st July 2020.
Sir, I think there are some
webinar was held by Rsacp Mumbai branch, and today also 30. So it's network issues. So is my audio clear, Vishal?
Now it is better.
Yes, now it is
audio? Am I
now it is
audible?
clear, sir.
Now it is
Please go
better.
ahead, sir.
Now it is better.
I will be brief. I congratulate and place it on record Rsacp achievements today we.
Sir, I'm afraid we've lost you again.
Sir, your voice is not is breaking, sir. I think there has been a heavy rainfall there.
Of Rsacp webinars.
Right.
I think Dr. Gauri, I'll join after some time. Please go ahead.
Sure, sir.
Gauri, what he wanted to say was that Rsacp webinar series started 2 years ago, and it was ISA Mumbai which started on the 1st of July 2 years ago, and now 2 years later on the same very day it is ISA Mumbai who's hosting this Rsacp webinar series. That is what he was saying.
It's a lovely coincidence that we're here today then. I now take this opportunity to invite our very dynamic secretary, Dr. Vishal Singla, to say a few words before we begin the assembly. Sir, you're muted, sir.
Thank you very much, ma'am, and good evening, everyone. Thank you to each and every one of you for being here with us today. Rsacp, as Dr. Naveen said, we have just completed 2 years of continuous webinar series, and we have had some very wonderful guests here. And today, with so senior faculty, I think more than a webinar, I guess it will be a classroom teaching. We have Dr. Amla and Madam Indrani, none else but Madam Indrani. Continuing in the same spirit, we will be holding webinars with the more relevant topics, not only in the field of anesthesia, but also in the fields related to daily day-to-day life issues like legal issues and keeping oneself calm through meditation. For today's topics, I would like to thank Team Mumbai, especially our President Ma'am, Honorable President Ma'am, Dr. Indrani Ma'am, for bringing in again a classroom teaching. I would also like to thank our chairpersons to, I'm sure the discussion is going to be lively. We have so senior faculty. And I would also like to thank Mr. Rahul Chaubeji for providing the technical support, for providing this webinar and live streaming this webinar live on Anesthesia Television and on YouTube. Once again, I would like to thank each and every one of you for being here with us today. And especially for the postgraduate students, I would like to tell you, please come up with your questions. No question is small. Every question, howsoever stupid you may feel it, is relevant, is important. We all have been through this stage. Please come up with your questions. Thank you very much, and looking forward to hear from the very eminent speakers. Once again, thank you very much. Dr. Gauri, please.
Without further ado, I think we can move on to the academic session. The topics for today are nothing short of a nightmare for any anesthesiologist. These are masses that are a problem. They're a problem in terms of the airway, they're a problem in terms of the vascular anatomy involved, and they're a problem in terms of the patients themselves. What to do, how to do, and how to go about such complicated cases is always a challenge. And to guide us through these challenges, we have some eminent speakers and brilliant chairpersons who will help us understand the topics and navigate such a tricky sea with ease. For our first topic, I now invite our chairpersons to help us. Our first chairperson is Dr. Sri Krishna Joshi, who is nothing short of a father figure for all the anesthesiologists, young anesthesiologists across the city. Sir has been an honorary assistant professor with the JJ Group of Hospitals and is now a consultant at the Shushrusha Hospital and Kaushalya Hospital. Sir has dealt with complex cases, diverse cases for so many years and carries this vast clinical experience with him, which he will now bring to the table. I welcome you, sir, for our assembly. We next have Dr. Manisha Katikar, who with us for this session, who is, as we all know, the president of the Maharashtra State Chapter of the Indian Society of Anesthesiologists. She's an associate editor with the IJA and the National ISA Coordinator for Clinical Cultural Events. Madam has received the prestigious Rukmini Pandit Award at the Rsacp Ahmedabad 2021. Welcome, madam. We're very, very happy to have the both of you with us. Over to you, sir and madam.
Am I audible? Joshi sir, would you like to speak?
Yes, ma'am, you're audible.
You're audible, ma'am. Please go ahead, ma'am.
Yeah.
Joshi sir is speaking.
Joshi sir is speaking, I think.
Yes, okay. I must say that the RSACP is doing a fantastic job of these webinars, and these two topics are so close to difficult ones which every anesthetist faces sometime or the other. And I think this discussion is going to definitely help, especially the youngsters who are going to come up and to face the music, how to tolerate, how to go around with these difficult cases very well. And I'm sure it will be a great learning experience for everybody. Thanks everybody from the RSACP for inviting me to be the chairperson. Thank you all. Thank you very much.
Respected Dr. Tejpal sir, Dr. Indrani madam, Dr. Vishal Singla, Dr. Bajwa sir, Dr. Naveen Malhotra sir. It is my great privilege to join this meeting, special meeting of RSACP branch of ISA Mumbai, who has complete 2 years for the webinar series. Heartiest congratulations, Indrani madam, for this great achievement. I am really very happy to join this webinar, as many of my friends and seniors from Maharashtra are the speakers as well as the faculties, and it is my proud privilege to join this webinar. Thank you very much for the nice introduction, Gauri, and thank you very much for inviting me here. And I must say that both the topics, Indradi, I must say that I am remembering my days in Tata as your junior, both the cases, massive thyroid or even a big anterior mediastinal mass. So I am remembering my days in Tata Hospital as your junior. Thank you so much.
Manisha, would you like to introduce Dr. Amla Kudalkar?
Yeah. Can the
Dr. Gauri, please, can you please
put her CV PPT?
Yeah.
Gauri, you can introduce her if you want.
So, ma'am, we now welcome Dr. Amla Kudalkar, who has recently joined the St. G.S. Medical College in KEM Hospital as the head of department anesthesiology, critical care and pain. She has just joined us after her vast clinical experience as a professor in the Lokmanya Tilak Medical College and Sion Hospital. Welcome, madam.
Shall I start sharing my screen?
Yes. Yes.
Are you able to see the screen?
Yes, ma'am, it's visible, ma'am. Please go ahead.
Yeah. A very good evening to all of you, respected teachers. I can see Dr. Krishna Doshi, sir. Namaste, sir. Today, I have been given this responsibility of discussing this case of patient with massive thyroid swelling by Indrani. And if you see, both the topics are more or less, similar or in continuity. So what we have decided is, I will be speaking mainly the airway assessment and intubation of trachea and extubation, whereas Indrani will take care of the intraoperative problems. This is a place where I belong to. Now let's see. You are aware that even if we consider thyroid swelling, a huge thyroid swelling, the spectrum is huge. Not all patients will have severe symptoms of obstructions. So not only one case, but I plan to discuss 2 or 3 cases. Let's see how we can accommodate them. This is a 45-year-old patient, female patient coming from Nashik. She is posted for thyroidectomy. Now, what history will you ask in this patient? Now, another disclaimer I would like to say that instead of the entire thyroid history, I'm going to just elaborate on the history pertaining to airway. Not only that, I will also see in examination or investigations only related to airway. So in case of history, we have to ask about duration and progress of the swelling. Why that is so? Because longer the duration of thyroid swelling, there are more chances of these patients developing tracheomalacia or pliable soft trachea. Progress, why? Because if there is continuous slow progress, usually the body adopts. But if there is sudden increase in the size of the swelling, there can be malignant transformation, there can be bleeding inside the tumor, or there can be infection and inflammation. So all these things you have to keep in mind. History of pressure symptoms and history of hemoptysis. Hemoptysis may be because of invasion of the swelling in trachea, mainly occurs during malignancy. One thing about pressure symptom is you have to ask pressure symptoms in both sitting as well as supine position. And why that is so? This is because a big thyroid in a sitting patient may not cause much problems because the swelling falls away from the trachea. It does not compress the trachea. However, as soon as the patient lies supine, then the pressure can actually, the weight of the tumor can compress the trachea and the patient may become symptomatic. So whenever you ask the pressure symptoms in both sitting as well as in supine position. Also ask about dysphagia, pressure on esophagus, history of dyspnea, orthopnea, stridor, that will indicate pressure on trachea and invasion of tracheal lumen. Hoarseness of voice could be because of the pressure on recurrent laryngeal nerve. If you can visualize in a big thyroid swelling, the recurrent laryngeal nerve gets embedded inside the tissue, and therefore there can be ischemic changes, there can be pressure, there can be traction of recurrent laryngeal nerve causing hoarseness of voice. Not only that, even mild laryngeal edema which is present in these patients also can lead to hoarseness of voice. So hoarseness of voice is a symptom that you have to reckon with caution. Then syncope because of pressure on carotids as well as because of the thyrocervical stele. Many a times patient complains of coughing and choking sensation during sleep. This is because, as we have seen during supine position, the swelling goes and sits on the trachea and causes pressure symptoms, but not always. Because if the patient is awake, usually the voluntary muscles of the neck, they will take care of it. But as the patient sleeps and the tone in the voluntary muscles goes down, the patient can complain of severe choking sensation and may get up with that. So a thorough sleep history in these patients is mandatory. And what you are going to ask them, whether the patient is able to sleep in supine position or she has to get up in between, which is the preferred position for sleeping, whether supine or lateral position she has to assume, how many pillows she needs to take, or some patients may need to just sleep in chair. So all this detailed history you are going to ask. Our anesthesia induction takes place in supine position. Therefore, if the patient is symptomatic during, while she is sleeping in supine position, of course, she is going to manifest during induction. So this is a very important history in these patients. So how to suspect retrosternal extension? Inability to get below the swelling, presence of facial edema, dilated veins in the neck and upper part of the chest, Pemberton's sign positive, and dull note on percussion on the manubrium sternum. What is this Pemberton's sign? You ask the patient to raise both the arms by the side of the ears. What happens is the thyroid swelling goes down in the inlet and it can press on the superior vena cava, thereby obstructing the venous drainage. So the patient may become cyanose also. So be careful while you perform this test. So what is the pertinent history that we are asked? Again, I will keep coming back to this patient. So it is a 45-year-old female patient residing at Nashik, comes with history of swelling in front of the neck, gradually increasing over a period of 10 years. So it is a prolonged course. There is no history of sudden increase in the size of swelling or pain in the swelling. There is no history of difficulty in swallowing, dyspnea while doing activity, or hoarseness of voice. So the swelling looks big, but she is more or less asymptomatic. Locally, if you were to examine, it is an anterior neck swelling, 15 by 12 by 10 centimeters in size, moving with deglutition, not moving with protrusion of tongue. It is firm in consistency with nodular surface, most probably multinodular goiter. In malignant swellings, what you usually see is the hard consistency, and the skin will be fixed, or the swelling will be fixed to the underlying trachea or the tissues. It is possible to get below the swelling except at one site in this patient. The trachea is deviated to right. Cocker's sign is negative. What is Cocker's sign? If you apply gentle pressure to the lateral lobe of thyroid, then it causes severe stridor, or it increases the breathing difficulty. It may be dangerous also. So that indicates that the swelling is engulfing trachea and causing compression of the trachea. Pemberton sign is eye signs are absent. Bruit over the thyroid gland, which is present, indicating it is an active gland. Let's consider investigations only for the assessment of airway. We are used to the first 2 or 3 investigations like X-ray chest, X-ray neck, epi and lateral. CT neck, nowadays we are doing quite often, indicating the thoracic inlet. Ideal, we were used to doing it traditionally. Now there are certain other investigations I would want to focus on, like rigid laryngoscopy with 70-degree scope, virtual bronchoscopy, flow volume loops, and airway USG. Now this is the same X-ray neck epilateral of our patient. You can see it is commensurate with the clinical findings that we saw on the inner picture. So there is lateral deviation of trachea. Compression is not that evident. This is the X-ray chest. Again, is a part of neck. You can see the trachea is deviated to right. What you can see here is, appreciate here is the widened superior mediastinum. So usually it is indicative of retrosternal extension. And this is the just a cut of CT chest. You can see this is the thyroid swelling deviating the trachea to extreme right. You can see manubrium. So you know that it has gone inside the chest. And these are the flow volume loops, as you can see. If it is a fixed obstruction, which is often caused by huge thyroid tumor causing engulfment of trachea, then it will be fixed obstruction. If it is variable extrathoracic, then inspiratory loop will be truncated, it will be flattened. And in case of variable intrathoracic, it is the expiratory loop which is flattened. So not only it indicates the presence of obstruction, but it will indicate roughly the location of obstruction also. Nowadays, with radiological imaging, usually flow volume loops have taken a backstage. How we are going to prepare OT for this? Now, I will be running through the cases, you will see the difference in the preparation according to that time period. This was done many years back, around 12 to 13 years back. So what was available at that time, we had kept ready. So different size of tubes that are understood. This is the iGel which had come there, King's Vision, Rsacp, and a Fruva, along with McCoy laryngoscope blade. My main concern of obstruction, for that I had kept rigid bronchoscope ready. Fiber optic, I would have wished to be keep ready. And this is, if you come across senior examiners, they would want you to keep this towel clip. And what is the use of this towel clip? This is because as we induce anesthesia, I mentioned that the voluntary muscles will lose their tone, and the swelling will go and sit against the trachea, causing obstruction. In that case, to lift this swelling away from the trachea, this towel clip was kept historically. We also prefer to manually lift the swelling or simply turn the patient in one of the positions in which he was comfortable. That's why the importance of sleep history and asking the patient beforehand in which position he is comfortable. Anesthesia plans if you were to consider. I would like to just give the postgraduate a quick look. If it is a small to moderate swelling without any compression on X-ray neck, if the patient is asymptomatic, well, routine IV induction, you can go ahead with that. However, if it is moderate swelling with deviation and compression of trachea on X-ray neck and mild obstructive symptoms, it is prudent to go ahead with inhalational induction. If ventilation is possible, again, relaxant can be given. Why inhalational induction? Because of the breath-to-breath control over inhalational induction. Intravenous agents, once you give them, you cannot aspirate it back. Inhalation induction, you can control, you can do the fine tuning. However, if it is moderate to huge swelling with compression and obstructive symptoms, then it is better to go ahead, keep the patient awake and breathing. So awake either fiber optic intubation or awake video laryngoscopic intubation, keeping rigid bronchoscope as a bailout gadget, or in extremely severe cases, one can go for femoral bypass also. Now, which method we are going to use in this patient? We have seen that she is not that symptomatic, though the swelling looks reasonably bleak. So intravenous line is secured. Patient nebulized in the preoperative area with lignocaine. Always, if you wish to go ahead with inhalation anesthetics, I would suggest always to do lignocaine nebulization, as if you would do for fiber optic intubation. That is because it obstructs the airway reflexes, and your intubation does not induce spasm in this patient, laryngospasm. So inhalation induction using graded sevoflurane, and then ability to maintain airway under deep sevoflurane was checked, and one can go ahead with short-acting muscle relaxants. The choice of tubes is varied, and if available, one should use flexometallic tube whenever there is big swelling, whenever there is extreme deviation of trachea, or whenever you on X-ray neck, you can see the airway is crooked. Why a flexometallic tube? Because these are non-kinkable, as you can see here, they are non-kinkable. So PVC tubes, if you use regular PVC tubes, if the patient at patient's body temperature, they become soft and then they can get kinked, even because of the crooked airway, also because of the surgical manipulations. Now, instead of the regular flexometallic tube, again, I would suggest you can go ahead, use the tube which is shown here. You can use the tube which is used along with ILMA. Why this is so? Because this is a tube which is flexometallic, it is reinforced, so it is non-kinkable. The tip is soft yet firm. So it is very easy to manipulate this tube through the obstructed airway. So always flexometallic, preferably ILMA tube. North polar tube also you can use, as it conforms to the airway anatomy of the pharynx and larynx. Also, it keeps our circuit away from the field of surgery. Another tube I would suggest to keep ready in case of difficult distal obstruction. For example, if there is retrosternal, as we go ahead with next subsequent cases, you will appreciate it better. Consider retrosternal goiter and the obstruction which is distal. A normal placement of tracheal tube is not going to bypass this obstruction. A dictum in thyroid surgery is that the narrowest portion of the obstructed portion of the airway has to be bypassed. The tip of your tube should lie beyond this obstruction. And therefore, if there is, consider a narrow trachea where you need to use a smaller size tube. But if you use a smaller size tube as here, like if you consider this 5 number tube, the length of the tube is very small. The length of the tube is very small. So if it is pushed too inside, hardly anything will be available outside, and therefore a similar kind of microlaryngeal tube can be used because of its increased length and the added size of cuff. We will come back to this point whenever we consider next cases. Another tube that is now, it is being used recently. These are the EMG tubes or nerve integrity monitor tubes. As you know, that recurrent laryngeal palsy is a very dreaded complication and reasonably common complication of thyroid surgery. That's why it is essential to do identify this recurrent laryngeal nerve. Usually, just identification of nerve does not suffice because you don't know about the functionality of the nerve. So it is better that you identify the nerve as well as check its functionality by during the dissection. And this is done by the nerve integrity monitor or EMG tube. These are the tubes with, there are two electrodes which are impregnated outside the tube. And these electrodes should come in proximity of the vocal cords. So every time you stimulate the nerve, you will see the sine wave form on the monitor. And then you know that you have to be away from this area. What are the intraoperative problems? Of course, Dr. Indrani is going to share more about it, but I would just like to highlight sharing airway with the surgeon. This can cause manipulation of the airway, causing airway obstruction, accidental extubation. Therefore, capnography should be used right from the first breath until you extubate the patient. So these are, and there can be disconnection of the circuit and injury to the recurrent laryngeal nerve. All these are pertinent to airway problems. What are the causes of respiratory diseases post-extubation? Vocal cord palsy, either unilateral or bilateral, complete or incomplete. It is the bilateral incomplete palsy which is of danger to us. Then tracheomalacia or collapsing trachea, formation of hematoma and hypocalcemia causing tetany and laryngeal spasm. So these are the causes of respiratory distress. So if you extubate a patient and suddenly find that the patient goes in distress, you have to rule out one of these causes. Of course, ruling out incomplete reversal at the beginning. That's why a robust extubation strategy has to be in place. And how do we do that? How does extubation in a thyroid patient differ from other patients? So usually we go for visualization of vocal cords at extubation. Age old, we used to do direct laryngoscopy. But imagine a patient who is coming out of anesthesia and muscle relaxant, and you want to insert laryngoscope. Then you give pressure so that you can visualize vocal cords. You strain your neck along with your surgical colleague to look at the cords, and the patient has developed tachycardia and hypertension. Nowadays, this is hardly practiced. So we go for video laryngoscope where most of the staff sees it at one time on the monitor. You don't have to retract, you don't have to leverage. So just video laryngoscopy extubation is done. Nowadays, even we don't do this. We go for FOB, a small either fiber optic laryngoscope or fiber optic bronchoscope, even pediatric would do. We insert it at the till nasopharynx or little beyond, and then through that panoramic view of glottis, you extubate. Once you extubate, you will have a grand view of cords, whether they are moving equally or they are adducted. So all this you will be able to appreciate. If you are suspecting that there is trauma during during surgery, or in case of tracheomalacia that is suspected, it is better to extubate over the fiber optic bronchoscope. So in this case, you pass the fiber optic bronchoscope through the endotracheal tube and extubate over the FOB. So bring out the tube first, then the FOB. And in such cases, actually, it is better to defer the extubation, beyond after 24 or 48 hours. And whenever you do extubate, then it is better to take these patients inside the operation theater and extubate over the airway exchange catheter. We are going to consider that subsequently. Now, how do we diagnose tracheomalacia? Of course, first from long-standing history of thyroid swelling, softened cartilages as palpated by the surgeons. Some people do ask us to remove the tube a bit outside. so that you can appreciate, so the surgeon can appreciate the collapse of the trachea or intraoperatively, but I would suggest that is not the way it should be. Perform leak test if tracheomalacia is suspected. So absence of, you deflate the cuff at the end of surgery. Usually, if there is no tracheomalacia, there should be leak around the tube. So absence of leak around the cuff when deflated. There is if there is no discrepancy between exhaled tidal volume with cuff inflated and deflated, usually the leak would be around 100 to 110 ml. Patient not able to breathe around the endotracheal tube with lumen blocked. And finally, the gold standard would be visualization through fiber optic bronchoscope of cartilages collapsing during the extubation. So these are the various ways in which you can diagnose tracheomalacia. You can see it here. So it is a dynamic bronchoscopic visualization, which is the gold standard. On the left side, you can see this is the trachea because now it is being stented with the endotracheal tube. As you remove the tube, you can see the trachea collapsing in front of your eyes. So in this case, anyway, the fiber optic bronchoscope is in place. So reinsert endotracheal tube, extubation trial after few days, and then ENT reference is needed. Another complication equally important is vocal cord paralysis. You can see here, it is both the arytenoids are at different level. This is bilateral incomplete paralysis. Why bilateral incomplete is more dangerous? Because it causes paralysis of the abductor muscles, causing the cords to adduct. If there is bilateral complete paralysis, then it would indicate the cords would remain in cadaveric position. So there will be a chink between the two cords. So though they are prone for aspiration, their sudden respiratory distress does not occur. Some people even do not advocate this fiber optic bronchoscopy or laryngoscopy to visualize movements of the cord. They are proponents of USG. So once the patient settles, you can always do an ultrasound of the neck. And what you can see here is, if you can notice, both the cords are different level. So this cord is paralyzed. Therefore, this arytenoid here is at higher level than this. You can see it better here. However, it is always better to do it under fiber optic guidance, or if you suspect, because after that again you will have to insert either laryngoscope or bronchoscope. So it is better to keep it in place. Another complication is post-thyroidectomy hematoma. Patient suddenly goes in distress. So immediately open the sutures. In fact, the thyroid patient should till the patient is shifted to ICU or high dependency unit, the trolley should never be dismantled. So keep everything ready. If you find that the patient is in distress and there is a swelling in front of the neck, usually it is because of the hematoma. Immediately open the sutures, allow hematoma to drain so the pressure comes out, and then achieve hemostasis after induction of anesthesia. Let's come to second case. Now she's a 48-year-old housewife weighing 58 kilos, a 29 BMI. She is hypertensive since 5 years, presents with swelling in front of the neck for last 5 months. Now, if you see, the history is not long-standing. Probably she has noticed it just 5 months back. Gradually increasing size, associated with facial puffiness, change of voice is 2 months. There is history of weight gain. She was found to be hypothyroid and on treatment, and she gives history of snoring and inability to lie in supine position. So she is little difficult than the previous case. Now, if you see closely, this is her airway examination, MPC class 4. There is restricted neck extension. And upon inquiry, she also gave history about cervical spine surgery few years back with fixation. So making the things worse. On examination of thyroid gland, what we noticed was a firm 8 cm by 6 cm swelling with multiple nodules involving both lobes of thyroid. It was non-pulsatile, there was no thrill or bruit. Movement with deglutition was present, but we could not get below the swelling. In fact, all over the neck, we couldn't get below the swelling. Pemberton sign was highly positive immediately within 10 seconds or so. So she developed facial flushing, distended head and neck, superficial veins on raising both the arms above her head. X-ray chest I don't have, but this is the topograph of her X-ray CT chest. And here you can see that the tracheal deviation is to the right. There is mediastinal widening. This is the X-ray chest lateral view, and you can see the swelling here. So clearly she has mediastinal mass. This is her X-ray, again chest X-ray prints, and you can see that there is narrowing of the tracheal lumen. And this is what I was more worried about. It is C1, C2 fixation of spine. So they remain in this position. You will not be able to manipulate their neck at all during intubation. And therefore, it was decided airway plan was awake fiber optic bronchoscopic intubation with CPBS standby. Now let's get to this standby type, So since how we went about it, again, full airway anesthesia. At this moment, I wouldn't like to elaborate much on this because of lack of time. But again, the same around 8 milligram per kg dose we can give as per the new theory. So we restricted ourselves. This was again carried out some around 10 to 12 years back. So around 5 milligram per kg of lignocaine we had given nebulized. And then these are the patties in the nase, both lignocaine as well as adrenaline. Afterwards, we instilled zolamethylzolin drops or Trivin drops for nasal decongestant. And since we could palpate the hyoid bone, we also gave superior laryngeal nerve blocks. The patient was in semi-sitting position. One additional IV line was taken on lower extremity. Now, why there is a need to take in line on the lower extremity? This is because these are the patients who have supra SVC obstruction, and any drug that you will give through the upper extremity veins may not reach the heart, and therefore it is very important that you take additional intravenous line on the lower extremity. An arterial line also was taken under local anesthesia. Now here, at this juncture, we always wanted to keep CP bypass ready because she was so symptomatic, and therefore femoral vessels were isolated. I mean, they were dissected under local anesthesia, and they were isolated, and a string was passed around them. So, in case of in case it was necessary, it would be easy to cannulate these. The bypass machine was kept ready. But on standby, and awake fiber optic intubation with airway anesthesia was carried forward. Now, this is what the patient was always in sort of sitting position only, and the operator was standing on the stool. And we use, again, if you can notice, this is the Ilma tube that I am using. And with this, I could successfully negotiate the trachea by using fiber optic bronchoscope. This was a huge swelling. Now, in her, majority of the swelling was in the thorax, in the mediastinum. This is the position post excision. We had kept the tube in situ. Didn't want to remove it. After 48 hours, so after 2 days, we removed it over the airway exchange catheter. However, 3 days after her extubation, so 5 days after her surgery, in the ward, she suddenly developed respiratory distress, and there she had to be intubated immediately, taking her to ENT/OT. After intubation, it was decided that elective tracheostomy be performed. It was done, and after 6 weeks, slowly she was decannulated and extubated. This is the third case, which is final. She is a 54-year-old obese patient with BMI of 43 kilo per meter square. She comes with a case of swelling in front of neck since 10 years, growing slowly in size. But of late, last 2 to 3 months, she developed progressive difficulty in breathing over last 3 years, dysphagia since last 2 months. She also had palpitations. Even this patient was hypothyroid to start with and was on L-troxin. She had dysphagia since 2 months. There is no history of hoarseness of voice or syncope, no history of hemoptysis. She had inability to lie down in supine position. I mean, throughout last 15 days, she used to be just in sitting position. She preferred to sleep in chair. There was a history of snoring and disturbed sleep in the night. As soon as she, was in deep sleep, there was increased frequency of arousal and daytime somnolence. So she had obesity. If you notice, she had hardly any swelling in the neck. This part of her airway was fairly normal. Even obesity was mainly in the lower half of the body. So airway, if you were to consider without thyroid swelling, it was fairly normal. But this was her X-ray neck. If you see, there is deviation of trachea to the right, and what you can see is the scabbard trachea. There was side-to-side compression of the trachea. Okay. This is the lateral film where the luminal narrowing is not that evident, but in the AP film, it is quite evident. Usually what you see on the AP film is the deviation of the trachea. And on the lateral film, you see the compression. But in case of scabbard trachea, where the trachea is compressed from both the sides, it is in the AP film also you see luminal narrowing. The same thing is evident here on X-ray chest. This is the narrowed portion and suddenly it disappears, the trachea disappears, airway shadow. And then there is this widening of superior mediastinum. Now this was also a challenge. If you see, if you were to trace this is the trachea. Hardly any lumen is seen. You can go on seeing here. Afterwards, again, it opens up. So distally, the trachea, much distally, it is again picking up. But for considerable distance, it is just chink or not even chink. And this is her CT film. There is a narrowing of trachea for 5 centimeters in length. So it was a big narrow segment with narrowed portion of trachea seen extending from C7 to T1 and T2 to T3 vertebral level with narrowing seen approximately 4.2 centimeters proximal to carina. The dimensions of trachea at its narrowest level are 4.7 by 1.8 millimeters. So AP wise, it is 4.7 and mediolaterally it is 1.8. So it is that small chink. That's why you will see the scabbard trachea there. So these were the dimensions and the symptomatology. Then we went ahead with virtual bronchoscopy. So what is virtual bronchoscopy? You would like to see what happens inside the trachea. CT will give you an idea about how much the trachea or tracheal lumen is compromised because of the pressure from outside. But this is the virtual bronchoscopy, which will give you a 3D reconstruction. So you must have got an idea about how bad the situation was. I'm so sorry. And this is the new technology that can lead to. This is the virtual bronchoscopy with 3D printing, which is available. So you get an idea about what is actually inside the lumen. However, this particular print is not of this patient. You wouldn't see such a big trachea, but make use of all this new technology these days. And this is another, I was saying about the ideal that we have been doing. But instead of ideal, why not go for 70-degree scopy? It is a very thin laryngoscope, rigid laryngoscope, the lens at the end of which it is at 70 degrees. So you will be able to see the, even if you insert your laryngoscope, the rigid laryngoscope at the posterior pharyngeal wall, you will be able to see the cords very well. And not only that, you can get the recording also, which is not possible ideal. With ideal, the patient may not be cooperative, and it depends upon the expertise of the one who is doing it. So see how beautiful it is seen. Yeah. So instead of ideal or in addition to ideal, one can always go for 70-degree scoping. It will give you. Now let's see this 2022 ISA guidelines on airway, ASA guidelines. Let's see whether the suspected difficult laryngoscopy. Actually, no. Laryngoscopy, if you see the airway parameters, conventional MPC and jaw protrusion, everything was normal. So it was not suspected. But difficult ventilation, definitely, be it with face mask or supraglottic airway. She was not at significant risk of aspiration, but she was prone to become rapid desaturation. In fact, one day prior, we had called her to OT, and there we checked her, wanted to check how far she can remain in the supine position. But immediately within 2 seconds, she became, really uncomfortable, and she desaturated. So there was never question of keeping her in any other position than sitting position. And of course, it was suspected difficult phona, front of neck access, because of the because inability to make her supine. In view of all this, we decided to go ahead with awake intubation. Now, awake intubation also, it can be either electively invasive access, that is tracheostomy, which we did not want to go for that option. So awake intubation, either fiber optically or using video laryngoscope. Now, this was just last year case, and we had other gadgets than what we had 10, 12 years back. Now, let's see how to make use of these gadgets. Again, lot of brainstorming was done between various, faculties, radiology, ENT, cardiac surgery, anesthesia, and then it was decided upon a plan. Now, let's see the merits and demerits of each. Awake fiber optic bronchoscopy. Many people thought and later on commented also, in her, awake fiber optic bronchoscopy should have been the first choice. Let me see first thing. In her, the area, the trachea lumen was very small. We did not have very small FOB. All we had was a small umbuoscope, but if you consider that there was extreme pressure on the trachea from outside because of the tumor, negotiating a small umbuoscope through that is extremely difficult. I mean, you need to try to be convinced about that. Also, there was doubt about the patient tolerating the procedure, because whenever you do fiber optic bronchoscopy, you are railroading the tube over the bronchoscope. So at one moment, your tube along with the bronchoscope is going to go across the fiber optic, across the tracheal lumen. Now, when you are doing for any other patient like, airway malignancy or so, your trachea is big enough. Here, the trachea was reduced to a chink, and therefore, and that too for almost 4.8 to 5 centimeters. It was a big narrow segment. So if you were to block this small lumen by the fiber optic scope and the tube, then patient would not have tolerated it. Third, as we said, that there was a need to bypass the obstruction. Now, fiber optic scopy is best done by nasal route. Usually, it is very comfortable that way. So, you will have to use it, you will need that extra length of endotracheal tube to bypass this long segment of tracheal narrowing. And since we are using a smaller size tube, you would that would not have been possible. Come to the second option, CP bypass under LA followed by induction of GA. This also we had tried. In fact, this case was taken up in cardiac OT. The patient was extremely obese, lower half. The USG scan was done and it was difficult to see the femoral artery and vein. So the cardiac surgeon, they expressed sort of their inability to cannulate it. Also, the patient was not able to lie down in supine position at all. So what we decided is, since her upper airway was relatively normal, she had a she had a Malampati grade of 2 or 3. So why not do awake oral intubation using video laryngoscope and a bougie? So visualization of cord was not expected to be difficult. And here we use the special intubating bougie. This is called as S-guide. This S-guide is hollow inside, so you can continue to give oxygen through that. Not only that, it has a very soft, firm, but tapering tip. So it is very easy to negotiate an obstructed lumen. So that's why we had decided to use video laryngoscope along with S-guide. So we could continue to give oxygen through this hollow tube. A rigid bronchoscope was kept as a bailout gadget. That is always a case whenever you need. Going on bypass at the last moment would take at least 30 minutes to start the bypass cannulate. But rigid bronchoscopy you can achieve in in very short time. So that should be your bailout gadget. And surgeons were ready for possible sternotomy. Let's see how we did it. Always we kept the patient. This is the maximum she could sleep, with this. Patient was semi-sitting position. You can see the high frequency nasal cannula, which is attached here. So with this, the period of safe apnea can go for a long time. So that was continuously on. So for no desat. Then IV was secured on upper as well as lower limb. Arterial cannulation was done under local anesthesia. In fact, it is being done at the moment. And then dexmedetomidine infusion was started from the beginning at maintenance level. So it was going for almost 20 minutes before we actually started attempting intubation. Again, same, the patient in almost semi-sitting position. I had to stand on the stool, and with best data, you can use anything, any video laryngoscope that you are comfortable with. This is the best data similar to CMAC, where I could visualize the cords very well. Through that, I passed the S-guide, and over that, we threaded the tube. Now, this was remember that in all these cases, as soon as you intubate the patient's airway, make it a point to attach the circuit and capnometer. Capnometer should start right from first breath. This was a tube. Now, the beauty in this patient was there was hardly any tumor mass in the neck. The entire thing was in the neck. But since the surgeon was really skilled and he could remove the entire thing through neck, as you can see, only neck. There was no need for doing sternotomy. Given the history, given her OSA, given her obesity, we had decided that we are not going to even attempt extubation on table. So we shifted her on ventilator. After 2 days, she was wheeled into directly ENTOT. We have where all the ENT surgeons were kept ready along with the gadgets. Again, if you see, you can appreciate this. HFNC was kept ready and patient was extubated after confirming the normal that she was awake, conscious, blast was good, cough flick test was performed, and she was extubated very safely. Of course, over the airway exchange catheter. So the take-home message would be, in case of this, details about the positional pressure symptoms or sleep history is must. Radiological imaging should include now the new varieties, CT scan, 3D CT scan, virtual bronchoscopy. Appropriate tubes, difficult airway cart, and expert clinician should be ready. There is no room for last moment hurry. Patient should always maintain in head-eye position or the position in which patient is comfortable. Supplemental oxygen throughout, so no desat technique. In severe cases, keep the patient awake. Most of those patients. So either you choose whatever gadget you are comfortable with. Fiber optic would be gold standard, but in the case that which I described, perhaps video laryngoscope was a better gadget in that particular patient. The bailout gadget should be rigid bronchoscopy. ECMO, if it is to be used, it should be a primary and elective option. You cannot run at the last moment. Always defer tracheal extubation because lot of, previously the patient has difficult airway because lot of dissection, edema can set in, there can be paralysis, there can be hypocalcemia. So you don't want to enter that situation again. So defer tracheal extubation. Always extubate the patient in operation theater with the same preparation that you would do for intubation and over the airway exchange catheter. And of course, continue to monitor. Thank you so much, all of you, for the patient listening.
Thank you, Amala ma'am, for the fantastic and thorough presentation. I think the one key word we're going to take away from this presentation is definitely going to be multidisciplinary brainstorming to manage such a challenging case. I invite our chairpersons to discuss the case further now and help us along.
It was an excellent. Yes, sir, please.
Yes, no, go ahead. No, I think it was an excellent presentation, and most important thing, at every step, it was the word of caution which was most important. Every step, whatever was done, there was always an alternative in case that failed. So that is most important to keep it in mind. Keep all the trolleys ready before you start any case. And whenever you have a doubt, always prefer local anesthesia, patient awake, intubate, and then do whatever else you want. I think it was a very, very well presented case.
Thank you.
Yes,
sir.
Manisha. Yeah.
Yes, it was really an excellent presentation, especially all the three cases. And as you said correctly, all different gadgets for airway and intubation, they were kept ready. And in fact, one case was managed in operation theater also. There are some queries on this, but I think Madam has already explained and given answers for all these questions. But still, I would like to ask them. Madam, for the first case, somebody has asked that suppose a patient becomes dyspneic on supine for fiber optic bronchoscopy, and after starting inhalation, if there is apnea, what to do? I think you have answered this, but still, again, if you would like to answer.
One thing is, for fiber optic bronchoscopy, there is no need to keep the patient in supine position. Patient should always be in sitting or semi-sitting position. I mean, that is the way it is done best. You are comfortable and the patient is comfortable. Inhalational induction, if you are contemplating, then always again head high position and slide. If you feel that as the patient takes more and more inhalation anesthetic agent and muscles start losing their tone, and if you find that the back movements are less or you are unable to ventilate, it is better to either manually pull the swelling away. Though the examiners kept on saying that it is you have to use the that towel clip, and also it is more of historic importance because it can cause injury also to the vessels or to the tissue. So it is better to pull manually the patient, or best is turn the patient in the lateral position so that the mass falls away from the tracheal lumen. So that I would do.
One more addition to this. Can I speak? Can I say?
Yes.
Am I audible?
Yes,
there are nowadays new towel clips which are non-traumatic. The clip part of it is something like a Babcock's forceps like thing. Therefore, those can be used in extreme difficulties. They can be used to lift up the muscle swelling. They don't cause any trauma, but in emergency, that's the best thing to do.
Yes.
Can you take some questions or after both the cases?
Can you unmute yourself, Nisha madam?
Yeah, there is a question for the third case especially. How you were sure that you have seen the cords on video laryngoscope, where they were seen in ideal or rigid laryngoscopy, and what was the dose of dexmedetomidine infusion? This was for the third case.
Yeah. We had done, I mean, she was never assessed for the first time on table. We had done multiple examinations prior, of which I have not mentioned here, but of which a thorough airway examination, as you would do for any other patient, like MPC. MPC was excellent. I mean, she had good mouth opening also. her neck was short, but her protrusion, mandibular protrusion was good. And if I were to tell you, I had done a quick laryngoscopy on the 1 day prior. Not only that, I had checked USG scanning also. So all these tests we had done, and so I was sure that I should be able to see the cords very well. Her problem started after, in the trachea, distal trachea. So if there were, I had to choose between fiber optic and video laryngoscopy. If the conventional fiber optic scope was there, perhaps I would have been tempted to use that. But the ambuoscope that I had, I had just pediatric ambuoscope, and that is, if you see, it is very pliable. It is not to be used in a swelling which is, trachea which is compressed from both sides. If you remember, the medial to lateral dimensions were just 1.8 millimeter. So it is difficult to negotiate such supple laryngoscope through that. So that's why I decided to use this S-Guide. S-Guide is excellent gadget. More than through, I don't know whether I should say it here, but it has a tapering tip. The tip is similar to the, again, Ilma's tube, intubating LMS tube. It is a soft, firm and tapering. So that allows it to negotiate its way through the even narrowest portion. So that's why I decided. Plus, it is hollow from inside. So you can always continue to give oxygen when you are inserting the tube, inserting the stillet here. That's why I decided.
Yeah.
And also you can give jet ventilation if you have really faced the
required.
Yeah, that I think she had shown me for the third case that jet ventilation was going on.
And also, I think very important to pre-oxygenate the patient well with high flow oxygen. That allows another 8 or 10 minutes more for your intubation. I think that's a very important, valid point, especially for youngsters who take over for such cases.
Yeah, another question is
that dexmedetomidine, it was kept at around 0.5 to 0.5 microgram per kg, because I did not give the bolus dose. But all these intravenous line, extra intravenous line, and the arterial cannula under local, it was going to take some time. So during that period, we started her on that with HFNC in place. So that answers that question, I suppose. So maintenance dose of dexmedetomidine, 0.5.
I think, Amla, you have done a fantastic job of presenting all three cases and made it look quite simple for anybody else, but it's not so. It's the most difficult part to do it. Well done, very well done.
Madam, there is a question regarding, even I have that question about airway exchange catheters. For how long you keep the airway exchange catheter? You are extubating the patient on airway exchange catheter. So how long?
Yes. So almost for, you have to err on the longer side. In fact, after this, it was within 10 minutes, there is no need of removal. You can keep it as long as, till you are sure that the patient is maintaining airway. So almost for up to 2 hours, I had kept. Patient was tolerating well.
Only thing, we have to ensure the complete awakeness and recovery of muscle strength.
Yeah.
That is.
It was after 2 days and they had recovered.
Madam, is there any observation like that the patients who have cardiorespiratory symptoms preoperatively, they have some cardiorespiratory problems, especially the hypotension and other problems intraoperatively? Is it your observation in all these massive goiters?
It is possible. You are right, as you said. Luckily, the second patient, she was hypertensive on treatment. But since it was awake and even in her, we had started dexmedetomidine. So no, she did not give, with God's grace, both patients did not give me problems on that front, So I could concentrate on the airway only.
Madam, I have a question actually. Ma'am, the presentation was brilliant. Like, it was super thorough. Ma'am, I wanted to ask you, when you extubate over fiber optic, you had recommended that. What would your recommendation be for preparing the airway at that point of time, considering the patient has to tolerate the fiber optic while you're removing the tube, but has to maintain the airway after also without the tube? So we can't have an obtunded airway, but we need them to be able to tolerate our scope as it goes in and the tube comes out.
Are you telling about the immediate post-operative?
Madam,
The first
instead of the airway exchange catheter, where you recommended that we could possibly
yeah,
put in a
yeah.
fiber optic scope and look while we extubate, that is where I was curious about with regards to what would be the ideal method of airway preparation.
See, fiber optic extubation over a fiber optic endoscope, I would think when I have to extubate this patient on table, see, if there is like the first patient I told you, that otherwise she was asymptomatic, but since she had a prolonged duration of swelling, there was a possibility that tracheomalacia would have been there. So in those cases, anyway, they are just coming out of anesthesia, usually dexmed may be going on. So at that time, there is the patient will tolerate your fiber optic bronchoscope also, because you are passing it through the endotracheal tube, and then gently see extubate. First, you remove the tube over. I mean, it is sort of railroading, and then gently remove the fiber optic. Patient usually tolerates, and then as soon as you see, if you see the tracheal rings getting collapsed, immediately you reinsert. Patient should tolerate that. And the remaining two, I said that we extubated over the AEC.
AEC. All right. Thank you so much.
Ma'am, shall I ask one question?
Yes,
Amla
sir.
ma'am, can I ask one question, ma'am?
Yes, sir. Yes,
Not
sir.
just question, just clarification. It was a good presentation. Regarding in one of the slides, you told that doing the direct laryngoscopy to at least examine the post-operative vocal cord status is not recommended. I'm considering the surgeries being carried out in so many centers with a varied availability of the airway equipment, varied patients, intellectual levels are different. The complication can occur anytime. Now, in 3 to 5% of the population, there is a unilateral, this one RLN, recurrent laryngeal nerve palsy is almost prevalent in 3 to 5% of the population. That's why the role of IDL is there. Now, when we post-operatively, if we don't do this, the laryngoscopy or examine the status of the vocal cord directly under vision, can there be chances that among all those 3 to 5% patients may have the bilateral RLN injury, and that we will be that problem? It's not our fault. Those are the surgical complications, but we have to manage those patients in the post-operative ward or ICU. How to proceed for such things?
First of all, I'm sorry if people are misinterpreting. I never said it is not recommended, but if you
This
have
school of
further
thought,
these,
another school of thought, another school of thought.
no, sir. What I would like to explain here is, if all these gadgets are not available, suppose you are doing only in the nursing home or area where you do not have these gadgets, you will have to necessarily look at the vocal cords. This is one. I mean, it is though I think in one of the lectures even I have heard in that many people nowadays they are differing from doing this, and instead they are doing USG guided. But still, I feel I would be comfortable if you look at the cords at the time of extubation, and that I have mentioned in my extubation strategy also. The first dictum is you have to know the state of vocal cords. How do you do it? Either direct laryngoscopy. If you have video laryngoscope, go for that. If you have the remaining gadgets, you can go for that. But if you do not have the sophisticated gadgets, it is important that you do at least direct laryngoscopy and check, you as well as the surgeon be comfortable that to know that the vocal cords are working properly. So visualization is must according to me.
Amla, I want to ask you.
I was just in that case, one thing that many times we recommend that when we are taking out the patients, almost awake patient, Dr. Madam Indrani was also talking about fully awake. In a cardiac case, especially in the cardiac case where even we don't always try to avoid the stress response, do you recommend any medication to be used before we proceed for the direct laryngoscopy to visualize the status of the vocal cords in such patients?
Actually, we reverse, and sometimes we continue with dexmedetomidine.
That I always love. I love that drug.
Yeah,
That at least it suppresses the stress response. It suppresses the stress response. But with a cardiac conduction blockade also in the cardiac patient, that is going to cause a problem for us. We don't recommend using dexmedetomidine in those patients.
Sir, I was wondering, Amira, I'm not wondering whether when you are going to visualize through the fiber optic laryngoscope whether the trachea will it be worthwhile spraying 4% xylocaine and then proceed with your fiber optic further down? It might help reduce the reflexes of
Sir, what we do is we just
Yes.
instill jelly in the nostril.
Correct. Right.
Yeah, and then this we are talking at the time of extubation, isn't it?
Yes, that's
So
what
we
I'm saying. Yes.
Yeah, so we instill jelly in the nostril, and afterwards we put in fiber optic. Actually, I have a small fiber optic.
Yeah.
So that we instill not throughout the length, just at the, once it goes beyond the nasopharynx, we stop at that level.
Just to see okay.
Yeah, so you can get a panoramic view of the cords,
Right,
as
right.
your assistant extubates, and then you can see the vocal cord movement from a
Correct.
distance.
Yes.
So
But
that is how.
if you're looking for tracheomalacia down, then it might be worthwhile giving a little bit of 4% xylocaine locally before you proceed with your fiber optic.
Yeah, but at that time, sir, what we are going to do is you are going to pass the fiber optic through the tube.
Correct. Right.
But sir, if you are giving 4%, its effect is going to last for another 10 to 12 minutes again. I
Correct.
think
That is, at least there, no sir, but at least there won't be any reflex which it can irritate and cause further rise in blood pressure and such things,
But sir, at that time, your fiber optic is going to remain inside the endotracheal tube.
Right. So there's no point. Yes. Correct.
Yeah. So what you are saying is the trachea ahead. So
Yes,
simultaneously remove both. Yeah.
Okay. I was talking of trachea ahead basically. Yes. Very nice presentation. I think we should compliment Amla for a very nice presentation.
Very absorbing.
Yes.
Thank you, sir. Thank you, Indrani, for giving me this opportunity.
What a fantastic presentation, Amala. You completely bowled us over.
And Indrani, we as chairperson, myself and Manisha, thank you very much for involving us in such a nice case presentation. Thank you.
Thank you so much, sir.
Dr. Gauri,
Yes, sir.
Let's go for another second session, madam.
After an enthralling lecture and an equally engaging discussion, we move on to our next topic, which is an anterior mediastinal movement. For this session, I'd now like to request our new chairpersons to join us. First, we request our very own Dr. Manjula Sarkar, who is a professor and in charge of cardiac anesthesia in the D.Y. Patil School of Medical Sciences, Navi Mumbai, who is recently retired as the HOD cardiac anesthesia in CHGS Medical College and KEM Hospital. Welcome, madam. Additionally, we welcome Dr. Sukhminderjeet Singh Bajwa, who has an impressive, if not envious CV, to say the least. Sir is the professor and head of anesthesiology at the Gyan Sagar Medical College and Hospital in Patiala. He's currently the associate editor-in-chief of the IJ, like we all know. Also the associate editor-in-chief of the JOACP. So has authored over 400 national and international publications. He has more than 8 book chapters, and I could just go on reading his CV all evening. Welcome, sir. Thank you so much.
Thank you, Dr.
Over to you.
I request Dr. Manjula Sarkar to introduce the speaker who doesn't know any introduction actually. Ma'am, you kindly do the formalities, please.
Thanks for a kind introduction of mine and Dr. Vajba for giving me this opportunity to introduce Dr. Indrani. Indrani doesn't need any introduction, as all of us knows well, but for the formal introduction, I have to say, at present, she is heading pediatric anesthesia department at CHGS Medical College, and she has retired as a head of the department from CHGS Medical College. Apart from that professional designations, she is very good friend of mine, and thanks to Indrani for giving me opportunity to be present on this session today. This is really prestigious discussion and session, and she's going to talk on the anterior mediastinal mass. Anterior mediastinal mass is in continuation with the Amla's talk, and we have to share the airway and we have to deal with the compromised cardiovascular involvement also. So over to Indrani for the your talk.
Thank you very much, Manju, for this lovely introduction. I would like to say that I'm presently working as Professor Emeritus in Department of Pediatric Anesthesia at KEM Hospital. Friends, mediastinal masses may be small, slow growing, or a large, aggressive, symptomatic tumor. So today we will be speaking about one, to understand the anatomy of the anterior mediastinum, recognize the common presenting symptoms of an anterior mediastinal mass, stratify the patient according to the risk based on symptom and preoperative testing. We already heard some of it. Anesthesia considerations in an anterior mediastinal mass, and a rescue plan during intraoperative airway or a cardiovascular collapse. So what would you do if you really had one? So coming to the anatomy of the mediastinum, anterior mediastinum, it is defined as, spatially defined by the sternum anteriorly. You have the sternum anteriorly, and the middle mediastinum containing the heart and the great vessels. And the thoracic inlet is on the superior side, and the diaphragm is there on the inferior side. This you can really appreciate it. This is the anterior mediastinum with the sternum, and between the sternum and the heart and the great vessels. Now, the structures which constitute the anterior mediastinal mass. Now you can find that there is a heterogeneous collection of benign or a malignant tumor. In adult, you may have the 4 dangerous T's, that is the thymus, the thyroid, the T-cell lymphoma or the teratoma, and sometimes the germ cell tumor. And in the pediatric population, you may have lymphoma, neuroblastoma, or neuroendocrine tumors. So in the order of frequency, you will find that the lymphoma is maximum, followed by thymoma, germ cell tumors, metastatic lesions, or all this. And thyroid is not very frequent, but my case is going to be an ectopic thyroid tissue. And what I would like to say is this is a real case, It's just aunt of my own husband. So who came up with this kind of presentation, which I'm going to explain right away. So coming to the case, she was a previously healthy 55-year-old woman. She came for thyroid surgery. She had compression symptoms, dyspnea, cough, especially on lying down. Manipulation and retraction of the thyroid gland was required to complete the procedure successfully. Scooping of the thyroid gland was done successfully without a need of sternotomy. The patient recovered uneventfully and was discharged to the ward on the same day. However, the patient developed cough with occasional breathlessness in the ward. That was considered as they just gave her some nebulization. She was discharged on the 5th day. After a week, the patient returned to the hospital with worsening cough, dyspnea, and bloating of the face. The patient in the hospital was tachycardic, hypertensive, oxygen saturation was between 89 and 90%, and she needed 4 liters of oxygen per minute to maintain a SAT of about 94%. During frequent bouts of coughing, the saturation fell less than 85%, and the severe orthopnea required the patient to sit fully upright. The chest radiography revealed a large anterior mediastinal mass with a tracheal compression of more than 50%, and Here, actually speaking, this radiograph was there even pre-operatively, and because of the presence of thyroid, it was understood that this is a retrosternal extension, which is the anterior mediastinal mass. And since the surgeon could scoop out the thyroid and remove it during the first surgery, he thought all is well now. But now, after the thyroid surgery, when we did the chest radiograph, we found the mass still existent in the patient. The CT scan was done now. There was severe tracheal compression. You can see that over here. Heterogeneous mixed density mass lesion lying over the brachiocephalic confluence here. SVC, right atrium, and the right ventricular outflow tract without any pericardial or pleural effusion. Now, an arterial cannula was placed in the right radial artery, which revealed a pulsus paradoxus of about 30 millimeter mercury. She is urgently being evaluated for resection of the mass. A sternotomy with a cardiac surgeon standby is planned for complete excision of the mass. So, in such a case, what is the aim of the preoperative evaluation in this case? So, you have to evaluate the risks associated. Depending on the patient's age, the nature, and the location of the mass, as well as presence or absence of symptoms, the associated comorbidities can vary greatly. On one hand, you can have an anterior mediastinal mass which is not giving any compression. And on the other hand, you can have a mediastinal mass which is compressing the trachea more than 50%, and also on the heart and the great vessels, especially the veins. So the next aim is to identify those with cardiorespiratory compressive symptoms and its exaggeration with exercise and positioning. Amala told you that you have to examine the patient in the sitting position as well as in the lying down position. Airway compression of the trachea or the main stem bronchus. Typically the patient will have dyspnea, cough, sometimes hemostasis, stridor, tachypnea, and cyanosis. Friends, the presence of stridor should alert the anesthesiologist that she or he is going to face a potential complication, and you have to be prepared. And presence of SVC syndrome has to be evaluated preoperatively. The SVC syndrome essentially because of obstruction to the venous drainage because of the presence of a huge tumor sitting over there. And the symptoms and signs is there is head, neck, or upper extremity swelling, swelling of nasal passages and larynx causing stridor, cough, hoarseness because of recurrent laryngeal nerve involvement, dysphagia if it is pressing on the esophagus, and sometimes visual disturbances. Visual disturbances, especially if you have a patient of thymoma, you can have visual disturbances in addition. Also, cardiovascular compression suggestive of chest pain, hypotension, orthopnea, dyspnea, dizziness, syncope, all postural, fatigue, and pericardial effusion. Remember, if the patient is complaining of dizziness and syncope, it could also be because of arrhythmias. Cerebral edema can occur in presence of huge tumors. We have had huge thymomas. In such patients, cerebral edema is possible. Patients will present with altered mental status, headache, vomiting, diaphoresis, signifying a raised ICT. In a patient in whom you still have to diagnose what the anterior mediastinal mass is, you also have to ask for systemic symptoms. Lymphoma may be associated with fever, night sweats, and weight loss. Thymic tumors with myasthenia gravis, as I said, eye symptoms like ptosis, diplopia, bulbar muscle weakness, so where there will be pharyngeal and laryngeal muscle weakness. Remember, these are the patients who are at risk for pulmonary aspiration of gastric contents, and skeletal muscle weakness also occurs with increasing as the day passes by. Thyroid masses with or without hyperthyroidism can be there. So you have to ask for presence of hyperthyroidism also in these patients. Frequently, the only symptom may be just a pain in the chest or fullness of the neck. So what additional information do you need to optimize in the preoperative period? And what is the significance of the symptoms? So one is, what decreases or improves the symptom of breathlessness? If the patient's head is elevated, does it improve? What happens if the patient goes prone? If you go prone, does it improve? Or in the lateral decubitus position, does your symptom improve? Remember, this is a very, very vital question to be asked to these patients, because your rescue maneuver will be this position when worsening occurs as part of your anesthesia plan. So how long can you lie flat? Can you lie flat only for a few seconds or few minutes, or you can lie flat well? So again, this is a very important question, because the minute the patient cannot lie flat, even for a few seconds or even 1 or 2 minutes, you know that you have a patient with compressive symptoms. Paradoxical decrease in blood pressure occurring with a change in position from upright to supine. So this is because of significant obstruction to right ventricular filling or ejection, and plethora of head and neck prominent cutaneous veins, suggesting SVC syndrome. The jugular venous distension is very prominent in these patients. And the other important vital information you need to know is whether the patient has received radiotherapy or chemotherapy, because the systemic the implications of radiotherapy and chemotherapy, presence of airway edema, all of them will count in as information in your preoperative period, so that you can plan the patient well. Cancer patients should be evaluated for the 4 M's. One is mass effect, that is compression of tracheobronchial tree. We already said that. Pulmonary artery, SVC, esophagus, obstructive pneumonia, lung abscess, Pankos syndrome, recurrent laryngeal nerve paralysis, or phrenic nerve paralysis. So they can have mass effect. Metabolic abnormalities, as you can see in myasthenia gravis, hypercalcemia, hyponatremia, or Cushing syndrome. Metastasis to brain, bone, liver, and adrenals, and whether they have had chemotherapy with say bleomycin, mitomycin C, doxorubicin, or cisplatin. So you can have the cardiac cardiomyopathy associated with these patients because of, and bleomycin can cause pulmonary fibrosis. So all that can be dangerous when you're anesthetizing the patient. Again, for tracheal compression, already Amla told you about the functional bronchoscopy. Remember, if more than 50% compression is there, of the cross-sectional area is there, we can have a fatal intraoperative airway compromise. And positional relationship of the mass to the airway to be determined to plan general anesthesia or even to avoid general anesthesia. So the mass, how it is positioned on the airway, that is also a very important thing which you have to know in the preoperative. Again, a tracheal cross-sectional area compression of about 30 to 70% with coexisting bronchial compression. So on one hand, you also have trachea as also a bronchial, left main bronchus or a right main bronchus compression. That is a catastrophic combination. Or a combination of a left main stem bronchial compression and a right pulmonary artery compression. Again, that causes complete ventilation perfusion mismatch. Again, this is a catastrophic combination. And the worst I would say is, if there is a right pulmonary artery compression and God forbid you put your tube on the right side, then it's a fatal combination. So remember, because there is no ventilation, there is no perfusion. So what investigation need to be performed in this patient? Apart from your complete CBC, metabolic profile, Serum biochemistry, you may have to do a coagulation profile. If you definitely, you may think of putting in a thoracic epidural in these patients. EKG, X-ray chest. Of course, X-ray chest will broadly tell you the size of the mediastinal mass and its compression on the airway. A CT scan with an IV contrast has to be done. That can give the anatomic location of the mass, also the static assessments, how big is the mass, extension and effects on the cardiorespiratory structures, the level of degree of compression of the tracheal and bronchial structures, and of course the cardiac and the great vessels, and presence of pleural or pericardial effusion. So in this case, we had the mass is extending all the way into the pressing on the right atrium, encasing the superior vena cava. The great vessels are displaced to the left hemithorax. And here, if you see, this is the inferior vena cava, which is so dilated because of compression of the mass on the inferior vena cava, and even the hepatic vein is dilated. So this is completely encasing the heart, the right atrium, the SVC sitting on the pulmonary vessels, and also it is sitting on the trachea. It is about 30 to 70% sitting on the trachea. You can see how small the diameter, tracheal diameter is. You can see here how small the tracheal diameter is. So definitely when you have such a case, remember there will be dynamic changes after induction of anesthesia. So these are the cases you have to think of performing, keeping the patient awake. A 2D echo will definitely tell you about the ejection fraction, the myocardial function basically, and degree of the mass, which is inside the heart, and compression, pericardial effusion, and the pericardial extension of the mass. All of them can be seen in this 2D echo. And of course, in this patient, the patient also, because it was extending right, there was tricuspid regurgitation in this patient. A PFT is useful in these patients, and a spirometry should be done upright as well as in the supine position. So these are the patients who may come out with obstructive and restrictive if the anterior mediastinal mass is compressing both the parenchyma of the lung as well as the bronchi. So the intrathoracic airway obstruction is accompanied by widening of the mid-expiratory plateau. This is the mid-expiratory plateau, which see this is in sitting position and this is in the supine position. And you can appreciate that there is a widening of the mid-expiratory plateau and a decrease of more than 10% of the volume is significant to say that there is a compression of the airway in these patients. So classically, what happens? Classically, there is reduced flow in extrathoracic operation, extrathoracic compression. You will find that the inspiratory limb is reduced, whereas in an intrathoracic obstruction, you will find there is a flattening of this curve and the expiratory limb is reduced. And in a fixed obstruction, you will have both inspiratory and expiratory both reduced. In a anterior mediastinal mass, such as a thyroid, you can have inspiratory obstruction, expiratory obstruction. It can be both, or you can have a fixed variable obstruction also. That is why Amla said maybe the spirometry is not the investigation to depend upon. So what are the other investigation? You can do pleural cytology, bone marrow aspiration, biopsy of the mass, MRI. If the patient is allergic to any dye or is a patient of chronic kidney disease, better to do an MRI rather than a CT. A technetium 99 scan can be done. Test to determine neurohumoral effects, if the patient is suffering from thymus, thymoma, or a carcinoid, then you can even do such tests. So what could be the surgical approach? One is patient can come for a diagnostic biopsy, or the patient can come for removal of the lesion. So for removal of the lesion, patient will have to undergo a sternotomy or a thoracotomy. For biopsy, it could be cervical mediastinal biopsy or an anterior mediastinal biopsy, anterior medianoscopy, or the mass can be excised from VATS, that is video assisted thoracoscopic surgery. Now coming to stratifying the patient based on symptoms and preoperative testing, it could be low risk, intermediate risk, or a high risk. Low risk patients are asymptomatic or mildly symptomatic without postural symptoms or radiographic evidence of significant compression of structures. So nothing to worry about these patients. These patients can easily go for an IV induction. So intermediate risk, mild to moderate postural symptoms are there, but the tracheal compression is less than 50%. So here is where you can even think about an inhalational induction. High risk patient, there is severe postural symptoms, stridor, cyanosis, tracheal compression is more than 50%, and pericardial effusion and presence of SVC syndrome is there in these patients. So what is the urgency of the surgery? Who are the patient who has to be taken up immediately, emergently, urgently, or electively? So if there is an impending distress related to the mediastinal mass, or if the patient is going to have an impending complete airway obstruction or cardiovascular collapse, these are the patients who have to be taken immediately. Urgently, if the patient is symptomatic, symptoms are increasing more and more, then these are the patients have to be taken urgently. An elective patient, if they are coping well, but the mass has a negative, has a negative impact on the quality of life. So in any case, it's better to remove the mass. So such patients can be taken up electively. For example, if there is cancer, you can give radiotherapy, you can reduce the mass size, and then you can take up the patient a little later. So to take up the patient of such a huge anterior mediastinal mass, you need to have a multidisciplinary approach. You need to have, of course, anesthesiologist, surgeon. If it is a child, a pediatric surgeon, cardiologist, cardiac surgeon. You need to have a cardiac surgeon standby and a perfusionist standby in these patients. ENT surgeon, again, to perform a rigid bronchoscopy. You need somebody to do a quick rigid bronchoscopy if you're losing the airway. An intensivist, oncologist, interventional radiologist, radiation oncologist. So at the time of induction, who should be present? An anesthesiologist, surgeon, CVTC surgeon, perfusionist, and an ENT surgeon in this case. So what are the issues which are affecting the management of the case? So there is a competition for mediastinal space with the vital structures. As you know, the heart, pulmonary artery, great vein, lung, and major conducting airways. Triggering factors following induction of anesthesia, like a supine position on the table and associated interventions such as neuromuscular blockade and positive pressure ventilation will exert profound effect on this balance, and you can lose the airway. Also, you have to understand with general anesthesia, there will be a loss in muscle tone and lung volume. There will be reduced expiratory flow rate. Already there is a reduced expiratory flow, and cardiac depression. There will be venodilatation. The diaphragm is relaxed and it will move cephalad. Again, there will be problems, and loss of negative intrapleural pressure, which is and the tenting effect, that will be there. and a tethering effect of the negative pressure, which is there during our breathing, sinus breathing, that again is lost. The tethering effect on the airways when we are doing a negative pressure breathing, that is also completely lost when you're giving general anesthesia. So all these problems will add to your already existing problem. And if on top of it, there is tracheomalacia, airway obstruction is imminent. So what are the issues affecting the management? So the diminished cardiac output due to direct compression on the SVC, pulmonary artery, or the heart itself is going to affect you, because the cardiac output goes, there's going to be a cardiovascular collapse. Airway swelling, there could be laryngeal edema due to SVC syndrome. Remember, the problem is there during intubation, more problem during extubation. So don't be in a hurry to extubate these patients. The decrease in cardiac index is primarily due to an increase in right ventricular afterload, the end result of which was decreased left ventricular stroke volume because of the effect on the ventricular interdependence. So just because it is just sitting on the right ventricle doesn't mean, so even the left ventricle stroke volume gets affected because of the ventricular interdependence. Tamponade-like effect by impeding the diastolic filling of the cardiac chambers, exacerbated if there is a pericardial effusion. And of course, side effects of radiotherapy and chemotherapy, as I already said. So what are the anesthetic technique for a CT guided biopsy, and what are your concerns? So remember, this is a diagnostic procedure. Anesthesia is extremely risky because emergence and recovery may be complicated by airway obstruction, especially because it is a diagnostic procedure, and also because the anterior mediastinal mass is not removed yet. And if you're giving general anesthesia, you had it. So best is, for such procedures, better to give just a local infiltration anesthesia. For intermediate and high-risk patients, please avoid general anesthesia in diagnostic procedures. LA, with or without sedation, you can give dexmedetomidine infusion. Radio, chemo, and steroids prior, as I said, you can shrink the tumor first. Awake VATS with epidural anesthesia, or just erector spinae block with paravertebral block combination. I said not just one, give both. Give erector spinae as well as a paravertebral block combination. You can do an awake VATS, that is non-intubated. NEVATS is non-intubated VATS. So that can be done under epidural anesthesia, or, as I said, a combination of erector spinae and paravertebral block. So remember, that can also extend into the postoperative analgesia. So in these patients, when you're doing the biopsy, you can feel that the patient is coughing. The cough reflex can be aborted with narcotics. And if feasible, if you feel that the mass is not that big, it's only mild, you can also give a propofol infusion in these patients. And if you remember, even ESPB or TPVB block, if you don't want to give, you can even try an intercostal nerve block. So that also can be tried. So masses with the anterior and superior mediastinum are readily accessible using a small anterior mediastinotomy under local anesthesia. Mediastinoscopy and thoracoscopy can also be performed under local anesthesia in motivated patients. Remember, we don't want to do from suprasternal approach. Many of the surgeons go through the second intercostal space. So that can be done under local. But please monitor the right-sided pulse for compression of innominate, and also monitor the peak airway pressure in these patients. If you are so you have to monitor for compression of the innominate. So in patients with severe airway compromise whose treatment is non-surgical, airway stenting can be performed as a temporary measure pre-op itself. As depth of anesthesia increases, if you're giving general anesthesia, I told you all the problems associated with general anesthesia. There is relaxation of the airway smooth muscle. There is a decrease in airway diameter with compression of the mass leading to airway collapse. A fall in FRC by 20% occurs. There is cephalid displacement. I already told you about all these. And remember, neuromuscular blockers can aggravate all of the above by relaxing of the chest wall, neck, and supraglottic structures. So the loss of spontaneous ventilatory activity decreases the transpleural pressure gradient, which under normal conditions serves to distend the intrathoracic airways and prevent collapse. So once you give general anesthesia, this transpleural pressure gradient is lost, and you will find that the airway is collapsing in front of you. Loss of normal negative intrathoracic pressure due to positive pressure ventilation increases the risk of compression of airway, heart and plate vessels by the tumor, and it can cause diminution of the. Here, if you see this, this is, there is the trachea is collapsing out here. And here is a patient who is spontaneously breathing and is completely awake. And here is the same patient in whom general anesthesia was given and a neuromuscular blocker was given. Can you appreciate the difference? There is a collapse of the airway in these patients. So if GA is planned for a large anterior mediastinal mass, remember a rigid bronchoscope and a skilled surgeon standby has to be there. Jet ventilation standby has to be there. A cardiothoracic surgeon for an emergency sternotomy and lifting of the tumor to abort the compressive effects. If all the above fails, have to be there. So these three persons have to be there with you when you're giving general anesthesia. What would you monitor? Standard heart rate, rhythm, SpO2, EtCO2, temperature, respiration, all these are there. Invasive blood pressure monitoring, CVC. Take a vein on the legs, urine output, airway pressure on the ventilator, ICP in presence of very huge tumors. Use a TEE to know the ventricular function, the tumor compression. Also, you can use it for management of IV fluids and vasopressors, and depth of anesthesia monitoring and neuromuscular block neuromuscular block monitoring if muscle relaxant is used. So what would be your anesthetic technique? What would be the drugs, airway management and maintenance? Remember, always have a IV in the lower limb, especially if the patient is having SVC syndrome. A femoral bypass, a femoral line has to be taken under local. Avoid pre-medication in patients with cardiorespiratory symptoms. Induction should be done in the upright position in patients with severe dyspnea in supine position. Awake fiber optic bronchoscopy should be done under LA because it permits real-time inspection of level of obstruction, the diameter of the airway, dynamic airway collapse, and mass effect. If this fiber optic is done pre-operatively, it is even better because you know everything about the patient. Inhalational induction with sevoflurane in moderate sized, moderate compression of airway when the compression is less than 50%. IV induction judiciously with ketamine, propofol, and dexmedetomidine. Remember, you have to give it very, very slowly and carefully. If the compression is not there, maintain spontaneous ventilation with LMA, second generation ProSeal, iGel, or Supreme. Intubation if CP bypass is need to be instituted. So initially ILMA can be used, and then you can put your tube through the ILMA. If you can pass the obstruction, then you can straight away put in a endotracheal tube. As Amla said, you can use the reinforced tubes to be put in. And if you feel that the obstruction is more distant, you can use a micro emulscopy tube. Okay. So there is avoid risks of upper airway. So this So if you do it very slowly, then you have also to be careful that you don't have any breath holding. I think Shilpa asked this question. Upper airway obstruction and laryngospasm, all this have to be avoided when you're doing, when you're giving general anesthesia. So as I said, you can use ML tube. If it is VATS, you can use a double lumen tube or a bronchial blocker. Maintain spontaneous ventilation and avoid paralysis in high-risk patients. If muscle relaxation is necessary, first try with a short-acting muscle relaxant like succinylcholine, and eventually, if there is no problem, you can give non-depolarizing muscle relaxants such as atracurium, which is a self-reversal agent, okay, and a short-acting agent. So in this case, ensure that you have a definitive airway and you are able to ventilate. Only then muscle relaxation can be given. So positive pressure ventilation and neuromuscular blockade after surgical decompression of the source. So positive pressure ventilation and neuromuscular blockade can be given after the surgical decompression of the mediastinum if you have been maintaining spontaneous ventilation until then. Plan B, if for securing airway, if you find that you're slowly losing your airway, remember, as I said in your preoperative, you asked at which position you feel more comfortable. You take that position, whether it is lateral or whether it is a sitting position. You have to have an ENT, as I said, to have a rigid bronchoscope. Or if you, it's always better to be safe than sorry. So have a preoperative stenting of the trachea or use a double lumen tube. And of course, as I said, cardiovascular thoracic standby, because they will have to do an immediate sternotomy and lift up the tumor. So I think I will skipping this. So again, the same thing. So the importance of rescue position is very important. So if this rescue position is not helping you and the patient has a sudden fall in blood pressure also, remember you have to give volume expansion in these patients and start vasopressors or inotrope in these patients because you're having a cardiovascular collapse in such a patient. And if even in spite of your volume expansion and vasopressor, the blood pressure doesn't turn up, then you need to ask the surgeon to do an emergency sternotomy and elevate the mass in these patients. So the next option you have is using a thoracic epidural along plus or minus paravertebral block. So use of regional anesthesia can attenuate the neuroendocrine response, facilitate rapid extubation, and improve ventilatory mechanics secondary to decreased narcotic requirements. So we know that we are avoiding all the problems of general anesthesia. T4 to T5 epidural placement or a segmental epidural anesthesia from T1 to T6 with inhalational induction or without inhalational induction, just under local, can be the main technique and then the patient is breathing spontaneously in these patients. As I said, a combination of erectospinal block along with paravertebral block does wonders in these patients. So if you give both with just a mild sedation will be good enough. It provides excellent postoperative analgesia. Again, as I said, intercostal nerve blocks also is an alternative. Remember, when you're giving these blocks, the LA absorption is very high and can reach toxic levels if you are not careful. So please aspirate and inject well in these patients. So this is the erector spinae block. So here you can find that this is the transverse process. You pass the needle, hit the transverse process, and just come out into the fascia and inject and look at the spread of the local anesthetic spreading both cranially and caudally. So that is erector spinae block for you. And here, this is the paravertebral space. So this is lateral to the spinous process. And what happens is you advance the needle to the paravertebral space. And then, here you will find that in the niche, which you see over here, this is the niche which you see over here. This is where you will have to inject the local anesthetic, ideally about 10 ml of 0.5% bupivacaine with 5 ml of 2% lignocaine does an excellent job. Same amount can be given for erector spinae block. So 10 ml of 0.5% bupivacaine along with 5 ml of 2% lignocaine. So if you're giving a combination of both, this gives you excellent anesthesia. Either of them can be given separately also, but it is useful as a post-operative analgesia. Now coming back to the case, the airway pressure is continuously high and the patient desaturates despite attempts at bronchoscopic adjustment of the endotracheal tube. The surgeons are scrubbing. What will you do? So what do you do now? Please, at the whole thing of repeating myself, I don't mind it. Here is the patient. Immediately alert the surgeon. Try your rescue position. Endobronchial intubation with the reinforced tube. Try to go past the segment. Urgent rigid bronchoscopy and jet ventilation. Immediate sternotomy to lift the mediastinal mass. So all or any of these can be tried, and the airway pressure and the saturation improves dramatically. If you have a good ventilator, you can even give a heliox mixture. In such a case, helium oxygen mixture with a critical airway obstruction from a large mediastinal mass will promote laminar gas flow and improve oxygenation and provide symptomatic improvement as well as facilitate the induction of general anesthesia and weaning from ventilator support. Of course, cardiopulmonary bypass is your last option in the management of critical mediastinal mass. Remember, don't wait for the last moment and ask the cardiac surgeon to go on bypass. You have to inform the surgeon. The surgeon has to have had a femoral line ready. In spite of it, it takes a good amount of time for him to go on bypass. Even with that, you can have neurological injury. So please inform the surgeon well before. It has to be established and properly planned. Especially you have a tumor, huge tumor compressing the right heart, pulmonary artery, SVC and all that. Remember, have a femoral bypass ready. So cannulation has to be done. So how will you extubate this patient? So remember, these are the patients which have had a chronic airway obstruction and SVC syndrome. So these are the patients who will have laryngeal edema. Long-standing masses can also have tracheomalacia. So, and these patients, you have to look for, as I said, recurrent laryngeal nerve palsy or a phrenic nerve palsy. So these patients have to be sent to the intensive care and remain intubated for at least 48 hours. Patient can also develop atelectasis. There could be massive blood loss during the surgery. And of course, in the post-operative period, it is our duty to give pain relief in the form of epidural or, as I said, all these facial plane blocks. So to summarize, a large anterior mediastinal mass presents a considerable challenge to the anesthesiologist. Avoidance of general anesthesia for diagnostic procedures is recommended, particularly when the symptoms are severe. Maintenance of spontaneous ventilation with general anesthesia is the cornerstone for management of high-risk patients. High-risk patients requiring general anesthesia for resection require a careful, individualized anesthetic plan with multiple therapeutic options, plan A and plan B, available to prevent or manage cardiorespiratory complications. Thank you very much.
Thank you, madam, for the wonderful presentation. I would now request our chairpersons to take over.
मैम मंजुला प्लीज आप स्टार्ट करिए.
आप नहीं करना चाहते हैं?
अरे नहीं मैम आप करिए पहले, मैं बाद में करता हूँ, पहले आप करिए.
Okay, fine. So thanks Indrani for really beautiful presentations and giving us the overview about the anterior mediastinal mass, depending on the site, depending on the location, depending on the size, and what are the different options can be used by anesthesiologist, what are the different points to be kept in the mind for the better management and for the good outcome of the patients. So I think there's no question for Indrani and she has explained very well. So
no question because Amla answered all the questions.
Okay, anyway, both of you have really done the wonderful job and both of you have really presented very well. So any question to be asked by the chairperson, well, any chairperson can ask any question.
Shall I summarize a little bit?
Yeah, please.
Oh, yeah.
Yeah. What I loved in this entire lecture was the way you were teaching about that intrathoracic and extrathoracic compressions compared with the, the loops and the graphs. I think that is a wonderful way to teach the PGs because both the lectures, Amala Madam and you, I think wonderful how to teach the PGs because these are very important. People, after passing from your MBBS, they just go into the practice. Sometimes they don't follow these things, but teaching these things, they make them, very wise people. Regarding the lecture, there was no shortcoming. Everything was fine. Everything was up to date. The theoretical part, the practical part, everything you took care of in a very beautiful manner. I just want to highlight 2-3 things here. First of all is regarding the surgical team. We always say in our lecture, every anesthesiologist lecture, we should have an ENT surgeon ready, we should have a surgeon ready. But what the caliber of that surgeon? No, you are facing a difficult situation. You are facing a panicky situation. Don't you think that surgeon will also panic? I will say rather have a surgical team ready there because single person can have a mental block during the management of complications. So I will always like to have a surgical team when such difficult cases are there because having one surgeon gives a psychological boost to our confidence. But what about his confidence in managing such cases? We are dealing with the life of a patient who is going to get endangered when the the real crisis come. So that is one point. That is very important. I will always like to have a surgical team with all his equipment ready to handle such airway. In airway society, we have got our airway society in India also. I also suggest there also. Don't just go by the anesthesiologist, how much we can do as an invasive, non-invasive intubation, retrograde intubation, invasive submental, or cricothyrotomy. Not like that. It's about the surgical team, their expertise in this thing. The next part is this case, what you discussed today is a very, very important case and they have to be done first of all in the tertiary care centers. They should not be handled by the nursing homes or even the multi-specialty clinics because these cases are going to land up in problems. We as anesthesiologists have always, keep cribbing about that thing that surgeons are not taking care of the patient post-operatively. But I will just ask one question here that when we anesthesiologists are there, we have to take our own grace, own dignity, own, respect ourselves. That there are ways to earn it. I always in a favor of the pre-operative rounds and the post-operative rounds regularly even for a simple hernia surgery also. The reason being very simple, don't expect surgeon to take care of such patients clinically precisely in a manner that they can able to handle any complication. Dr. Amla, she said about that patient developing the respiratory distress on the 5th post-operative day. Isn't that? So what I say, the post-operative round should be the combined responsibility. We anesthesiologists, what we see, अब हमारा काम हो गया, operation theater खत्म हो गया. केस खत्म हो गया, रिकवरी में 2 घंटे बीत गए, अब हमारा काम खत्म है, हमारा कोई इसमें रोल नहीं है, सर्जन को संभालने दो. I will tell you that surgeons are not capable of handling those cases. Not every surgeon, few are, I think, good. Many of the anesthesiologists here must be having the spouses as surgeons or gynecologists or whatever thing. It is our duty that as anesthesiologists, we should evolve more precisely now in the coming days. Try to take care of the post-operative period, because majority of the complications are in the post-operative period. Peri-operative period, we are very vigilant. The teams are there. Post-operatively, the staff nurse is there, or technician is there, or even a JR, a PG resident is there in the institutions, or MBBS in a hospital. So those are the most crucial times where we, lose the sequence of events, how the patient get deteriorated. The post-operative rounds are very, very important. I have, written so much about it also. As well the pre-operative round, because in the pre-operative round, you will anticipate what degree of post-operative care that patient can take. The description of this mediastinal muscles was excellent, no problem about that. But just wanted to add these things to that description. The theoretically part was very good, ma'am. I really loved that. Today I was feeling like a PG student listening to both of you, and really absorbing. And I think there are must be some questions also. They were in chat box, and I like Dr. Manjula Sarkar to take over from here to ask those questions to the speaker.
Question from Dr. Naresh Paliwal for Indrani. What if GA is to be avoided and while putting epidural you get accidental dural puncture?
I'll follow him. Segmental spinal.
Yeah, even I also follow you.
I think that's okay. You can give a segmental spinal.
So segmental spinal can be given, right?
Yes. Or you can go for a combined, as I said, erector spinae block with a paravertebral block. You can do that also.
So,
but now that you have already punctured, go for a segmental spinal.
Okay. Thank you, Indrani. And no more question. And as Dr. Vasba has said it, that these lectures were really good for the PG student. And as today we are behaving like a PG student only.
Yeah. I love to be a PG student again and again, listening to such eminent speakers. Your knowledge always get refreshed. You cannot read these things again and again. You don't get time, you don't get energy. You have so many commitments when you grow up as a professional in your career. These type of things, they teach you again. Newer points come to your mind. I think that what was a brainstorming was the management of those cases, the 3 cases told by Dr. Amala. Those were beautiful cases. And the way she taught, it was just like I was feeling my PG, the way you teach in PG student, but in the precise manner.
Yes.
That was more important.
Okay.
Anybody wants to ask questions, please kindly. Ma'am, Indrani madam कभी मिलते नहीं है, ये यूएसए में घूमते रहते हैं 3-3 महीने. इंडिया में बहुत कम मिलते हैं ये. इनको पूछो क्वेश्चन, आज मिले हुए मुश्किल से फंसे हैं यहाँ पे.
No, I think all the students can ask any question even in the future also to Indrani directly, and she is always available. And I'm sure that she love to answer all the PG students' question. So no problem at all for them. And now I think we hand over to Gauri for concluding.
Thank you.
Thank you so much, Manjula madam, for the handover, for a lovely session. And I completely agree with you, madam. Indrani ma'am is always approachable. You can go to her with the smallest doubts and she will have an answer for you, and she'll answer it patiently. Before we move on to the vote of thanks, Indrani ma'am, would you like to say a few words for all of us?
Indrani says something for everyone. I like to compliment her for an excellent talk. I know my net connections were not stable in the earlier part. Heartiest congratulations, madam, for a very nice lecture. And I echo the words of Dr. Bajwa that I also sat through as a student and enjoyed listening to your talk and both the talks. And as I was saying earlier, today is an historic day. Today we are completing 2 years of Rsacp academic webinar series. We started on 1st July 2000, and today we are on 30th June 2002, 2020 and 2022. And coincidentally, Dr. Indrani is scoring a hat trick. She plans this like that way. 1st July 2020, Rsacp Mumbai. 1st July 2021, Rsacp Mumbai. And again, 30th June 2022, Rsacp Mumbai. So, heartiest congratulations, madam, for taking always a keen interest. And we shall be meeting next week again for a simulation-based workshop. And on 24th of July, 2 to 6 p.m. on Rsacp Founders Day online program. Thank you, madam.
On the 7th, we will be doing a patient safety workshop.
Patient safety workshop in a physical manner.
Yes.
Naveen sir, important thing. This is under the banner of the very architect of Rsacp.
Yeah, Dr. Blessings always with us, and we look forward to his blessings and advices always. Thank you, team Rsacp. Thank you.
Yes. I also take this opportunity to thank all the stalwarts who are present over here, and to remind everybody that our chairpersons Manisha and Dr. Bajwa are here, and they are contesting for the ISA election. Dr. Bajwa is contesting for the secretary, and Manisha is contesting for a GC member. And with folded hands, I'm requesting all of y'all to please support them. Thank you very much.
Thank you, ma'am, for the nice support, ma'am. Thank you.
Over to you, Gauri.
Thank you, ma'am. We now move on to the vote of thanks.
Dr. Gauri, I think I want to hear from something from Dr. Kaul sir also.
Of course, sir.
It's a historic day that we should hear from him.
Of course.
Kaul sir.
Kaul sir?
You want me to say?
Yes, sir. Yes, sir.
Superb presentations by both the speakers, and the Maharashtra state, particularly the Mumbai branch of the Rsacp, has been in the forefront of academic activities of Rsacp. Dr. Indrani is doing a tremendous job in seeing that the academic programs are improving every day. We are proud of you, Dr. Indrani, and Rsacp must thank you for your efforts in all fields to see that Rsacp is developing tremendously.
Thank you very much for your blessings.
I would like to say just one point. When we were students, we were taught that eternal vigilance is the price you pay for the safety of the patient. Today, after hearing both the speakers, I think this needs to be changed. Not only the eternal vigilance, but a proper pre-operative evaluation and the optimization and the availability of the optimized equipment. These are the two more points to be added to ensure the safety of the patient.
Sir, if you heard Amla speaking about all the three
Amla was
cases,
superb. Yes, I know it. I just meant that this
in a very short notice, she gave this presentation. And if you had noticed her when she went through those cases,
yes,
how she did the pre-operative evaluation, what was her plan, everything was in place, and what is plan B?
Absolutely.
So
Dr. Bajwa's comments, as usual, are very helpful. They are very informative, and we become wiser to hear from you time and again. He always makes the academic sessions very interesting and easy to understand. I must applaud both the speakers, madam. You have been superb, and so has been Dr. Amla. And best wishes to both the contestants who are contesting and who are here in this webinar, for the secretary of Secretary ISA and the general body GC member. My best wishes to all of you. Long
Thank you,
live
sir.
RSSCP. Long live RSSCP. Thank
Thank
you.
you, sir.
Thank you
Thank
very
you,
much.
so much.
Thank you, sir. Dr. Gauri.
Gauri?
Yes, sir. So today we leave today wiser, more cautious, and enriched by the teaching from both our respected speakers. With their vast clinical experience and meticulous research, they made sure that these usually complex topics became easy to follow. It clearly shows their passion for teaching and their unique perspectives on patient safety. In addition, I'd like to thank our respected chairpersons for sparing their time and joining us today. I'd also like to thank our patron, Dr. Kaul, for joining us and sparing us with and sharing his wisdom with us. Thank you so much for joining us this evening.
Thank you. Long live RSACP.
Long live RSSCP. Long live RSSCP.
Long live RSCP.
Long live.
Jai Hind.
Thank you.
Long live RSSCP.
Thank you so
Good night
much.
all.
Thank you.
Good night.
Good night.